So, so Dr. Muthu was for one, one of the chairpersons I had in mind. Then I wanted Professor Rajpurkar, and unfortunately he could not join because he and many others are involved with the Kerala State Nephrology meet going on right now. So he had to excuse himself, and Hardik himself was busy with pujas. And Dr. Akash was very much involved in the case. So he was there not only with this, he has other cases also, but we are going to restrict to only renal artery uh, stenosis and interventions. Then Dr. Vel Aravind, I thought because he is somebody, a nephrologist, who has his hands into surgery also. So he'll be a right person to, uh, pick up points, which could have led on to those renal artery stenosis in some of these cases. And I thought his wisdom will add to our discussion today. Then Dr. Vinant, who had experience of both and exposure to a huge number of transplants in his center and general prevalence and incidence of renal artery stenosis and how they were diagnosed in his center and who manages them. I was very interested to get to know this. And so he is the other chairperson, guest person with us today. And I was particular to have him here for another reason because just now we have, or rather he has released this book on interventional nephrology very successfully, and which has attracted a lot of tributes from many of our colleagues. So I thought let Inform be the first forum where people directly after going through the book. See, maybe in the release time it was different. So I wanted him to be here, and I'm happy he's here, although there were some hiccups in his hospital before joining this. So welcome all the panelists and the speakers. I am the other one who is going to present the case. But something I should tell about Dr. Muthu. So he was from Tirunelveli, son of the soil. He finished his MBBS. He went on to do his MS in Government Stanley Medical College, then Madras Medical College for his MCH. But there are many, who have taken this path, but not all are risen to his stature. His special interests are reconstructive urology, transplant, endourology, uro-oncology, and complex vascular access surgeries. And he has a lot of awards and things to boast to you or tell you. He was awarded outstanding educational video end-to-end urethroplasty in Canada, which was showed at Glasgow in March 2014. From there on, he has had many accolades. And more than all this, so this anybody can read this, but next you'll see the list of places where he was instrumental in starting renal transplant. See, he started renal transplant program wide across the country, in Guwahati Medical College, in Tanjavur Medical College, Tirunelveli Medical College, Kanyakumari Medical College. See, all these medical colleges were government colleges, and he was not in government service when he went to start all this in these colleges. He was a private man, but yet he found time and he was willing to go there, give them confidence, start and help them with their first transplants. Then, of course, other places like Velamal Medical College and SR Medical College. And he has been my transplant surgeon for the last 200 cases. Earlier, it was Professor Chandrasekhar, his teacher. Then, I was very apprehensive who would, fill the shoes of Dr. Chandrasekhar. And now we have, more than that in the form of Dr. Muthu. So, Muthu, I'm glad to introduce you to this audience of forum. I don't know whether you'll be aware, this is a nephrologist forum discussing interventional nephrology, and we are all by ourselves only some guest people. And I already told about Dr. Vinant. He's the senior consultant nephrologist in Sri Gangaram Hospital. after his DNB in Gangaram Hospital, and he has been there as a consultant nephrologist for a long time now. And more than that, he is into a lot of academic positions and organizational positions on a national level. And his interest in publishing papers and also writing books, and his pregnancy work, and now this interventional nephrology. I think such an young age to have achieved so much is something I and I got closely associated with him after this relationship through this book. And I'm glad he is here. And Vela Ravind, I think he would join us, although this will be the grand dinner time. He said he will come, but he will, his perspective on this subject may throw some good lights, I thought. And the other presenter is Akash, whom I already told you. He's been in Adiat for 3-4 years, and he has imbibed much of the traditional wisdom from that place. And he is here to not only present, but I wanted him to discuss the causes and go into all, some theoretical knowledge from him I want to learn today. And I think I'll start the case. And okay, where is and mostly I present cases not to show off, but to learn from others, because I do things in my place by myself without much guidance, and I finish it. Then only I get to read about it. I get to discuss with others. So my main intention of presenting cases here and all is more to learn than to show what I have done. Yeah, so this case was a 51-year-old female. He was in dialysis for 4-5 years. And she had a lot of comorbidities like CID, poor LV, severe MR, moderate TR, severe PHT. And I thought no way she could have a transplant. There were no related transplants, donors. And this, I was so reluctant to take her up for cadaver transplant, but in May 25 this year, she was taken for a transplant. And that kidney came from Velammal Hospital, Madurai, which is 3 hours away. And the cold ischemia time was nearly 5 to 6 hours, actually, because they release the kidney only after their surgeon, comes out of the harvesting. And so it takes at least 6 hours. And she was on a regular ATG prophylax and triple drug regimen. And for our surprise, things went on so well, and the nadir creatinine 0.9 was reached within 3-4 days. And I was so elated by the result because such a bad case, and things seemed to work well. Then by August 8th, she was admitted for fluid excess and pulmonary edema. So, but creatinine was only 1.1. So my first thought was it was an congestive failure due to a cardiac ailment. So something terrible has happened to her cardiac status. So the cardiologist was called in, and it was managed as a cardiac deterioration and nothing to do with the kidney. So within 3 days, with diuretics and his medicines, she looked better, and we discharged her. But she came back on 18th. That was when we started worrying terribly, because she came with oligonuria, anasarca, and her creatinine was 5. Then, because of the graft dysfunction, we did a Doppler, and Doppler was diagnostic, and it gave me the clue that it was renal artery stenosis. And she had been started on Sigmas by the cardiologist, during her follow-up with the cardiologist in between. So it was only 3 days or 4 days of Sigmas, and she landed up on 18th with this oligonuria and pulmonary edema and sickness. So
Dr. Bala, what is SIDMAS?
Oh, sorry. It is your
It is valsert and secubilateral.
Yeah,
It's
yeah.
ARNA.
Okay.
Yeah.
Interesting.
Okay.
Interesting.
Interesting. Okay.
So we are aware that it can, bring in acute pulmonary edema in a case of bilateral renal artery stenosis or single kidney with renal artery stenosis, causing, acute renal failure and pulmonary edema. So, but anyway, that gave me a relief that something which we could try. Then she was taken up for Doppler. Where is the Doppler? Oh. So Doppler was typical Parvus Stardust. Yeah. So that I really rejoiced because I'm always looking for this pattern in my renal patient, both in native kidney and in transplant. So then she was hurriedly taken up for renal angio. And usually I start with the MR renal angio for fear of spoiling the residual GFR and things like that. But this time around, things were so clear and there was no time to lose. So I took her straight for CT angio, and this is the picture I got. So it was a very tight stenosis, probably in the anastomotic area, and it looked very narrow. Taken in different angles, and it was surprising that there was so much perfusion into the kidney, considering the narrowness of the stricture or stenosis. So then she was taken to cath lab, rushed on the same day. It was a Friday night actually. And my place is Tirunelveli, where cath lab is there, many, and a lot of cardiologists are busy with their work. But renal intervention happen now and then. We generally have time to get hold of a renal stent and start doing things. But that day, renal stent was not available. So, that couldn't make me wait. I tried in the nearby cities and cath lab. So not before Monday, I could get a renal stent. But I didn't wait. On Saturday itself, I took her up for cath lab angiogram. And this is the video showing catheterization of the right internal iliac. It was an end-to-end anastomosis of internal iliac and the renal artery. So it was accessed through the left femoral puncture and crossing over the aortic bifurcation and reaching the right common iliac and entering the internal iliac and studying the renal artery. And we could cross the lesion easily, and we went on to put in a now this I think you would require more discussion later. So this was a cardiac stent, and you realize from the pictures that the vessels were large enough to call for 5 or 6 mm renal stents, but cardiac stents don't go beyond 4 mm. But now we have some of these advanced cardiac stents. The details I may not be able to tell you, but I tell you the stent I use, which are supposed to have some open strut, and it can be dilated even up to 5.5. So we started with a 4 stent, and which was dilated up to 5. Then as we were trying to dilate it further, and the next attempt, as expectedly, the stent migrated. And I don't know if it is clear here. 1 minute. You see, the stent has migrated here. So the narrowing was somewhere here. Because this was slightly smaller for the requirement, so it migrated. It made my heart stop for a while because I was doing with something very unorthodox. It has migrated, but we didn't stop there. We brought in another stent. I knew that this stent can't go beyond this because you have the bifurcations, and this stent cannot progress any further, advance any further. So the second stent, we took a longer stent, and we put in the longest stent behind the first one with minimal overlap. And the final result was no, actually this has two stents, one here and one here. And the final result was looked good. And promptly she started putting out urine, and the creatinine started coming down. Within 2 days, her creatinine was back to 1, and she was discharged. And now it is nearly more than a month, and she's fine with a normal creatinine. But looking at the video carefully and thinking back, I realized, see, initially when the guiding catheter was passed to the internal iliac, when we were hurriedly trying to pushing it until the stenosis, it had actually gone beyond the stenosis itself, the guiding catheter itself. So there was no hesitation to put in the guide wire. But that gave me some other hint, which we'll discuss after the case. So this was a case of a transplant renal artery stenosis in a cadaver transplant patient, which happened within 2 months, and which was worsened by, giving ARNI and and which resulted in a sudden deterioration of the renal status and the pulmonary edema. So this is actually, we went on to dilate till 5.5, but you see there is some kinking sort of area because there is some space between the stent and the vessel. I hope that with time, this enlargement of the renal artery might have been something like post-stenotic dilatation. So hoping that it might, come back to its original size and wrap around the stent well. So we came out, and as the patient recovered well, so we are happy so far. But the implications of using a cardiac stent in a renal artery problem, and also keep in mind that I realize this is a coated stent, unlike bare metal stents, which are generally used for renal artery. So the implication of that also we may have to discuss after this case. So we'll quickly move on to the second case by Akash, so that we can combine the discussion because as people join. Akash, share your screen.
Yes, sir.
I don't know how different is going to be your case, but the term battle lost, war won, I think something interesting you're going to tell us. So let
Yes,
us
sir.
discuss the the causes and the implications after your presentation.
Yes,
First
sir. Yes,
case and what you did.
yes. So we have a case of 42-year-old gentleman who has DKD, underwent renal transplant surgery with wife being donor. HLA mismatch was 9/12, no DSA, flow was negative, CDC was negative, he was ABO incompatible, received ATG as induction, and standard triple drug immunosuppression was started. So the catch here was it was an obese patient and it was a robotic renal transplant. He had some delayed urine output after 40 minutes because the cold ischemia time was prolonged. His creatinine fell nicely from 6.9 to 4.6 on day 1, and drain was removed, Foley was removed, DJ was removed, and creatinine at discharge was 1.3. The anastomosis was done from end to side fashion for vein and end to side fashion for artery, and renal artery was anastomosed to external iliac artery on right side. So first event was 17 days post-transplant. His creatinine increased asymptomatically from 1.3 to 1.9 milligram. His graft biopsy was done, which was suggestive of acute tubular injury, and DS and C4D were negative. He was requiring 2 antihypertensive at this time. His tacrolimus was high, which was adjusted. Creatinine further increased in 2 days from 2 milligram, from 1.9 to 4 milligram. This time we had our radiologist who routinely does our Dopplers with us. At that time, the RI was 0.6, but the peak systolic velocity at anastomotic site was 400 centimeters per second. In external iliac artery, it was 120 centimeters per second. The parvus pattern was seen. The late peak was seen in the intrarenal vessel, but diastolic flow was reduced and RI was still not very low, which we typically see in our classical cases of renal artery stenosis in native kidney. So what happened here was he already had TAC toxicity. He was very close to his transplant. He has acute tubular injury. So his intrarenal pressure was already raised. So his diastolic flow was not that great, which we typically see in our atherosclerotic renal artery stenosis. Though we found out that there was aliasing of color at the anastomosis, there was high peak systolic velocity was more than almost 3 times compared to the proximal segment and aorta. So what we did was we went ahead and did a CT scan. So at our center, it is routine practice to do a CT scan when we strongly suspect renal artery stenosis, and we know that it might benefit the patient, because with MRI, what we have seen is, sir, in atherosclerotic stenosis and in thrombosis cases, generally MRI overestimates the stenosis. So we go for contrast CT. Especially in transplant renal artery stenosis cases, we always try to do CT angio to delineate the exact anatomy. And this is the 3D reconstruction of the external iliac artery and renal artery, where we can see that this is 1.4 mm diameter at stenosis, and it was almost 2 mm long. Here we can see the kidney. It is a reconstructed image, and we can see the stenosis here, which was in the renal artery at the anastomotic site. So patient, this was on 9th of March, and ICC final was going on, and patient from CT table directly was taken to cath lab. So this was external iliac artery. So from same right side, we took access by 6 French sheath, and with an RDC, we took the access. So here we can see that the catheter is in external iliac, and this is the classical view. So because it was a robotic transplant, the kidney was slightly in line with vessel, so we could not see it in the classical view. So we took an oblique view, and here we saw that there is a stenosis at the anastomotic site. So we engaged, and we took an angio again, after which we passed a 0.014 cyan blue J wire in the graft kidney. And then we dilated the stenosis with 3 mm NC merge Boston Scientific balloon. So in renal artery cases, generally this dilatation by 3 mm balloons are just to accommodate the stents. And after dilatation, we can see what was the angiography. So now at least there is a way for the stented balloon to go into it. So here we confirm the position of the stent with angiography. It is well in the feeding vessel and also beyond the stenotic site. So generally we keep 1 mm in the vessel if it is native in the aorta, if it's in the transplant renal artery, in the external iliac or internal iliac. So the size chosen was 5 mm by 15 mm bare metal stent. The balloon was inflated. This is the picture after stenting, and this is the final picture. Patient received 8,000 interferon heparin during the procedure, but post-procedure he started on dual antiplatelets. After 2 hours, femoral sheath was removed and heparin infusion was started. But his urine output reduced, creatinine increased to 7 milligram, IGV DLC was put, and HD was started. On 15th day post-procedure, patient still had HD-dependent renal failure, So we did a biopsy with due precaution, which showed ATI but no rejection. So the transplant renal artery stenosis is different from native because the dynamics is very high. The rejection is going on, the reperfusion injury in early part is going on, and there are multiple things. So we wanted to know how much more to wait. So biopsy, we stopped clopidogrel for 5 days. Aspirin 75 milligram was continued, and 5 days, 4 days before biopsy, we gave heparin to cover for diuretic antiplatelet. After biopsy on next day, patient complained of graft site pain and had reduced urine output. So we feared whether it was thrombosis of the stent or whether it was rejection, because patient was off tacrolimus this time, only on steroid and MMF with wife's kidney. But his BP was also 100 systolic of antihypertensive, and hemoglobin also fell. We did sonography and we found a large perinephric hematoma, but no signs of paging. DLC was already there. We gave 3 PCVs, continued dialysis, and then he was on single antiplatelet. After 1 month of plasty, patient started having good urine output, and creatinine trend started to go down. So on 18th of Feb, his transplant was done, discharged with creatinine of 1.3, and then he had acute kidney injury, which we thought might be because of tacrolimus, high level of tacrolimus. His creatinine further increased to 4 milligram. Then on 9th, as I said, we did transplant renal artery stenting. His creatinine slightly improved, but he continued to require dialysis. So we continued the dialysis, and after a month, he became dialysis free, and his creatinine after 2 months was 1.4 milligram. Currently, his hemoglobin is 13.6. He's off antihypertensives. His creatinine is 1.2 milligram, and his tacrolimus is also acceptable. So message is we fight each battle to win the war. And transplant renal artery stenosis generally is seen from 3 months to 2 years time. But we may see it in early period, which might be because of King's clamp injuries or donor-derived transplant renal artery stenosis. Post-transplant hypertension prevalence is high in 80% of patients post-transplant, irrespective of renal artery stenosis or not. So patient on tacrolimus can not have hypokalemia and alkalosis, which we routinely see in native kidneys. So other signs like resistant hypertension and Doppler findings are to be sought after. And Dopplers are also different from natives because sometimes the diastolic flow might also be decreased because of acute tubule injury and tacrolimus going on or a rejection ongoing. Severe renal dysfunction due to clinical and sonographically suggested RAS is rather a strong indication for doing contrast CT angio when we think that revascularization might benefit the patient. Early intervention, at least 10 days to 2 weeks post procedure, saves nephron, because in early 7 to 10 days, the anastomotic site is very immature to do any plasty, and generally we go for anastomosis in those cases. So someone asked in the chat room that how early can we do the procedure? Absolutely no in first 7 to 10 days. After that, we have to do CT scan, and we have to take the call. In transplant setting, renal dysfunction may be multifactorial, and patients close volume monitoring, small solute monitoring, and USD monitoring are the key to see for recovery after even after revascularization. Thank you.
Yes, thank you, Akash. I think having heard these 2 cases, can I invite comments from the faculty and audience? And Dr. Muthu?
Yes, sir.
A surgeon would never like to, see a case like this, I'm sure. But Muthu is happy because both these cases were not his.
No, not like that. I would like to thank first for you giving me this opportunity to join this August audience. And yeah, it's quite interesting to know the problems, and managing the problems is quite challenging, especially renal artery stenosis. And both the cases are managed very well. Like the first choice is the angioplasty. There's no doubt in that, and there's no role for surgeon in the early first point. If there is a fail in attempting angioplasty, then the surgeon roles comes, and that is also a difficult surgery to do that. Hope you remember we had a case, and that was managed surgically. And
Yeah.
so my question is, like, it's the first case you had, like that's a classical presentation of CCF. That's one of the classical presentation to define the renal artery stenosis. And CCF is one of the clinical manifestation of transplant renal artery stenosis. And so you took a challenge to put a cardiac stent. So could you have waited for another day or two that till the renal stent would have come?
It was now it is easy to think like that, but then I was on my end of my wits and tips of my toes, because the 2 days weekend, if only the whole thing shuts off, and so, I mean, I don't know whether it can happen like that, but I was very worried, and that made me take that decision. And I did consult people and did some reading about using cardiac stent in renal arteries. There has been precedents even from outside the country, out of necessity and urgency, and not much difference, they say, if only the size could be attained. And the fact that they were drug-coated stents, the use of platelet inhibitors and aspirin and things, they have to be very aggressively followed. Generally, in renal stenting for native renal artery, or for bare metal stenting, we are not so careful doing it for a very long time. Maybe after 2-3 months we stop, or even if they miss, nothing happens, because large sized vessels and thrombus chances are.
Clopidogrel we stop, sir. Correct. Only 75 milligram. Actually, in one of my patient who had bilateral native renal artery stenosis, she started having a gum bleeding on 5th day of post stenting. We had to stop all antiplatelets then and there only, because she had torrential bleed. She did well for a month, and then after taking care of everything which was dental, we started her on only 75 milligram of aspirin. So clopidogrel we can easily stop, sir.
Akash, but that may be true for a bare metal stent. For
Bad
this,
matter, sir. Bad matter,
yeah,
sir.
for drug coated, so that is what
No.
I had to, run through literature and ask people, and in what way it differs. Then my lesson I learned was I cannot stop this easily.
No, sir.
Yeah.
6 months dual antiplatelets we have to give.
Yeah.
Sir, can I have a question for Muthu, sir?
Yes, please.
So, Muthu, sir, a surgical question. So, the first case Bala showed is anastomosis to the directly end-to-end internal iliac artery.
Yes.
So, normally we do with external iliac artery. So, what situations do you consider end-to-end to internal iliac artery?
No, the anastomotic stricture common causes are like fibrosis. One of the reason may be the disease, that atherosclerosis, 40% of them due to atherosclerosis. Whether the donor vessel had this is a cadaver donor, and was there any atherosclerosis in the donor artery, one cause. And tissue handling, I prefer not to touch the intima of both the donor as well as the recipient artery. That is very we have to be very careful. When you touch the intima, you are likely to produce some damage to the intimal hyperplasia and fibrosis bound to happen. And the first case, it came after 3 months. It's a quite usual presentation of renal artery stenosis. Whereas in Dr. Aka's case, it came, they have diagnosed within 2 weeks of post-transplant. And if you are diagnosing within post-transplant, maybe technical error, one of the could be the reason for renal artery stenosis. And other causes like there are literature support, like when you go through that end-to-end have a more anastomotic stricture compared to the end-to side. But I was reading through the Peter Morris today. It shows that the end-to side have a more problematic than end-to-end. That's what Peter Morris says that. And of course, if you do a non-touch technique and spatulated anastomosis of both ends of the renal artery and internal iliac artery, and the chances of renal artery stenosis is very less.
Okay, thank you. So coming to the next, the coronary stenting. So, so my practice being, we use IVUS for accurate measurement of the renal transplant artery. So we have enough cases to say we use coronary stents, especially when the vessel diameter is 4 millimeter or 4.5, because they have more accurate stents than the normally made stents. So that's the one. And there are, some of them are balloon expandable. They can increase from 4 to 5.5 with one size. So, and they come in short length. So Bala sir, what he was using, I was just surprised. I mean, what length was that, sir? Because it looks like bigger than the stenotic length. So that's what, one of the reasons why it pushes itself forward.
Because I didn't want to miss the lesion or the stent jumping and all that. So I played safe with slightly longer stent, but in had it been a regular thing, it is usually 2 centimeter only. But my cardiac stents that time, we chose this. You may be familiar with this Medtronic's Onyx Frontier. It is supposed to be that open stent thing which can be expanded up to 5.5, they say. So, and also the way my guide wire, not the guiding catheter itself, 6 French guiding catheter itself went in through an apparently such a tight stenosis in the 2D pictures seen, gave me an impression that it could be a twist also. So,
it's lucky, sir. With such guiding catheter going through that tight stenosis, your heart might be like,
yeah, because
the time of...
it was not intended to cross it.
Yeah.
So it, this is actually looking back at the videos later only I realized. Then again, I was looking through the videos again and again, whether it was, structural stricture or it was rotation, because it was a cadaver transplant done by a team which was not my regular team. So I was not very sure. But even now, I'm not sure whether it is a twist or a stricture. So the way the stent, see when you see the, let me show you the see, it looks as though you'll have difficulty even putting in a 2 mm pre-dilatation balloon, right? But your guiding catheter going in easily, and 4 mm cardiac stent dilated up to 5 mm migrating, such a long stent. It was a 4 centimeter balloon. So it should be, it should be stuck here. No, the waist should be holding it tight here and shouldn't be crossing. All this keeps telling me that it could have been a twist. So, I don't know whether I'm right. I want the surgeons and you and other interventional people here to guide me on this, because such a narrow stricture, I don't expect the easy crossing of this, and pre-dilatation would have been also difficult with 1 mm or 2 mm NC balloons. But this is a naive thinking, because I entered into troubled waters without knowing much, and now you come back, Dr. Ram.
So a few things, sir. So first protocol, I'm just going back to the basics. We don't do CT angios because I'm not a nephrologist, but I always concerned of the contrast nephropathy. So we do Doppler and then ultrasound and then MRA maybe or may not. So we directly go for, based on the indication, go for the angiogram intervention. Contrast, before contrast, we try to use CO2. We want to avoid as low contrast that we can use. So the lowest contrast, we would have sort of 10 cc's of contrast, the whole procedure is done with using a CO2. But a precautionary for CO2 is you have to make sure there's no, ASD or anything so that the system can cause air embolism. So that's one thing you should be careful of. Coming to the angiogram, like you did, we give a nitro before trying to negotiate the stenosis so that you have some chance of dilation. And we give a loading dose of heparin just before ready for intervention. The basics we use is a 014 system. And the dilation with 014 system, we try not to go with the 035 system. And the loading dose, once the stent is deployed and everything, like I said, we always check with IVUS to make sure that the accuracy of the length, accuracy of the diameter is perfect. We put them on 3 months of clopidogrel and aspirin. After that, followed by aspirin. So this is standard, in a straightforward case, I would say. So recently we had a dual renal arteries, not a single, a dual renal arteries. We could only dilate the main, the accessory was so small. So we just plasted it and we could not stent it because the angle was so difficult. So we could not do it. So sometimes angioplasty itself might be, what the patient might need at the time.
Ram sir, which guiding catheter do you use, Ram sir, for crossing this lesion?
So, see, this is where surgeon's input comes to me. It all depends the angle of the anastomosis with the external iliac artery. Is it way up, way down, or way posterior? If I know that, the planning is easier. So we try to come contralaterally. So contralaterally, you can use the couple of sheaths called arrow sheaths or Balkan sheath. Balkan sheath is a U-shaped sheath, which is routinely used by vascular surgeons. And we use a guiding catheter. So guiding catheter is a 6 French guiding catheter. We leave the guiding catheter in the main native artery. From there, we use the micro wire, micro catheter if we can. If it easily passes, you don't need a micro catheter. If it doesn't pass, we use a 2.4 system micro catheter. And we use a 014 system, completely 014 system. If you're coming from the other side, be careful of the length of the wire because sometimes the catheters are too long. So you have to make sure you have an exchange length wires. In newer versions, you are getting a monorail. Monorail means you don't need longer wires. You have a side hole. So normal length wire should be sufficient. So it's easier to come from the other side. Same side is always a challenging because the distance from your entry point to the intervention is very short, but your length of the catheters are too long. So manipulation sometimes might be trickier if the angle is difficult.
Yeah. Yeah, Ram, thanks for all the inputs. But in a center like mine, the resources, you don't have much choice. And another thing is internal iliac to renal artery rather than external iliac. See, my center has been majority, it is internal iliac to external, to the renal artery, end to end rather than end to side. That was because way back in 96 when we started transplant, the surgeon, even now sometimes it happens, they would do and they would leave. So I would never want to have a complication on the second or third day. And even if there is a complication, I would want my local surgeons to handle it easily. So if it is end to end, they will be able to, correct it or at least get away removing the kidney safely. But if it is end to side, the issue of, separating from the anastomosis and closing the external iliac and the problem of possible thrombus in the external iliac and the limb being affected. My previous surgeon used to be very wary of, because maybe he has lost 2-3 limbs in his large series of cases. So he always used to prefer the internal iliac. But now I find that people, there are many centers, they use only end to side with external iliac, but we continue to do, first choice would be end to end with internal iliac, and we do that. And Muthu has been also nice to continue my own old practice in my center here. I don't know at heart what would be his first choice. We'll ask him anyway. And the other thing, Yeah. So the hardware I used were very simple, which I showed, and I didn't have any difficulty. Yeah, it was a guiding catheter 6 prime. This is the one I always use, even for my AV fistuloplasties. I remember people asking me, we don't need guiding catheters at all in fistuloplasties. But I have come across many situations where your regular guide wire will not go. 034 will not go and 014 would be required. Then to put in a small guide wire, we need a guiding catheter. It won't go into a diagnostic catheter. So guiding catheter has always been part of my armamentarium, and it was a simple JR, and we don't have any this is easily available in the cath lab of any cardiology frequently occurring place. And and the run through point 014 we used because we expected there could be difficulty in passing, and then pre-dilatation was done with again as it easily went, we went used 4 size 4 mm balloon and pre-dilated. Then the choice of the coronary stent, that I had no idea of these stents, but all I wanted was some stent which can go beyond its size, beyond its native size of, the labeled size of 4 mm to at least 5.5. And they said this Onyx Frontier, and I think Ram should be able to come out with other models as well. And we did a post dilatation using a 5 size Tensi balloon. So these were the simple hardwares we used, and we didn't have much difficulty. The critical point here I wanted from the audience is whether this is a kink or a, it's a twist and kink or a stenosis.
Sir, can I make a point?
Yes, yes.
The twist is always at near the hilum. Even there is a twist at the anastomotic side, that finally it will come to the near the hilum. This is more looks like an anastomotic side narrowing. Doesn't look like a kink.
Right, Muthu, you may be right, because I have another video to show you all, which was definitely a twist. Where is it? Yeah. So this was a case of actually a twist rather than a kink. And as Muthu said, you see that, it is, the kink is lower down near the hilum. Right, Muthu?
Sir. Usually it will, because the force is completely, the kink will be more progress towards the hilum.
With this point, I didn't really know. When you say, I realize, and I see the video of this is my own case done nearly 10 years ago. Okay. And this was the final result. And you see that the waist in the end of the thing also, there was a waist in the stent, and everything has happened close to the hilum. This is a point I learned today, but having the whole record in my hand. And this case is now nearly 10 years past the stenting. Patient is doing well. Actually, in fact, I don't know whether I have told Muthu, this was again a cadaver transplant, and after anastomosis, there was no flow. So the surgeon was twisting the kidney this way and that way, and one position there was good flow, and there was good urine output. But then we realized that the kidney is upside down. So he had rotated the kidney so much, the ureter was going up. And then I said, no way you can do it again, because I know I didn't have the heart to, detach and allow them to do a restart. I said, you fix it that way. Let the ureter go up and come down. Let us not bother. And it was left like that. But after 4 to 6 months, this problem came, creeping creatinine, and Doppler gave me the clue, and then I went and saw this and put in a stent. And I was not sure how long, because teaching is that for a twist, it should be surgery, right, Muthu?
Yes.
Not stenting.
It's a twist mainly because of the complete 180-degree
Yeah,
rotation.
so ideally, with a good setup and surgeons, they should go in and do it. But I don't know how later, like this case. But I put in a stent because all I was, that time I was so enthusiastic doing renal artery stents in native kidneys, and I was so, sort of thrilled with that. And so I quickly did this, and now I realize it is nearly more than 10 years past the stenting, and she's doing well, the patient. And the causes of renal artery stenosis and the duration at which this can occur, any guidance, anybody can share whatever they have come across or read about. So if something happens within first week or two, like Akash's case,
It is most probably, sir, technical error. First, up to first 3 months, you can encounter technical errors. Routinely, they present early, and generally they present when patient is in the transplant ICU only. After 3 months, the causes start to differ. Sometimes we have elderly donor who has atherosclerotic vessel. Those kind of atherosclerotic transplant renal artery stenosis generally come between 3 months to 6 months. And 1 year and beyond, generally we see atherosclerotic, and sometimes we also see atherosclerosis in the external iliac arteries when we see a TRAS beyond 1 year. Also, we have encountered situations where there was a pseudoaneurysm just before the anastomosis, and that aneurysm was compressing the renal artery. So that also is possible. It's rare, though it's definitely possible.
I can remember another situation. It was a very young recipient, I think 10-year-old or so, and the kidney was from the parent, and it was large. And now I know everybody would do a end-to side because even end-to side with the common iliac or even aorta, right, Muthu, in very small built children. But in that case, it was surgeon's error. He did a with an internal iliac. So, which appeared to be functioning well when closing, but after that, next day, urine output came down, and I picked up the Parvus TARDIS. Then we opened, I'm sorry to say actually, and again, surgeons manipulated the kidney, and with lifting up the kidney, because pushing the kidney down, the kink was going off. Because there was no space in the pelvis, it used to migrate up, thereby taking the internal iliac with the acute bend. So with the positioning of the drain tube and all that, and fixing the kidney, some position, it started functioning. But later again, after 1 week, slowly developed. But at that time, it was long ago. I didn't have all this knowledge, nor my expertise in cath lab and things. I think we had to lose the graft. So it was again a surgical judgment error, where it should have been ideally an renal artery to the external iliac in that case, not even or even common iliac rather than internal iliac.
Yes, I do agree with you. The pediatric transplant, we have to go higher up to the common iliac, maybe in the aorta, not to use the internal iliac. And especially the pelvis is small, thin abdomen. And when we suturing also, we have to be very careful. Many a time we don't close the even the abdominal wall, may proceed something like a page kidney. And we have to put interrupted sutures, and just we have one case we have to just close the skin and came out doing well.
Sir, may I tell a few words, sir?
Yes,
Sir, I'm Dr. Pooja from Bangalore, Ramaya Medical College.
welcome.
So we recently had a similar case of transplant renal artery stenosis encountered in the second week. And initially patient had it was a live related transplant, mother to son, 40 years was the donor age, 20 years was the son. A little prolonged ischemia time was there, probably 1.5 hours cold ischemia time. So initially there was some ATN, and then within 4 or 5 hours it recovered and he had good urine output. By day 2 again the urine output started coming down, and we really didn't have any idea as to what was happening. And by day 3 there was nil urine output, and the perfusion in the kidney was a little poor. But 3 times or 4 times we had done a Doppler, we couldn't get that typical TRAS picture, sir. It was just showing that some perfusion is low. We went ahead with a biopsy showed ATN. However, I had given ATG to kind of help along with this. But by day 14, 15, there was a slow decline in the graft function, like creatinine would come down, but patient started building up volume and accelerated hypertension requiring 4 drugs with almost 15 kgs weight gain. And then incidentally, one more Doppler just like that was done, which picked up the TRAS. And then there was such a dilemma amongst the urologists. We had to really convince them that definitely this has happened. It was just at the level of anastomosis. And our interventional radiologist placed stent. Following that, it's been 2 days now and he's pouring out urine like anything. So they were actually not agreeing it as a surgical thing. Rather, some were commenting that it could be ATG related. Is it so, sir?
How was the Doppler and who did the Doppler? You did it?
So Doppler was done by the radiologist. He is the HOD radiologist, sir. So he picked up that there was severe constriction at the anastomotic site with parvus tardus in the flow with post-stenotic dilatation, everything, sir. Then we requested our cardiology team initially to do the angiogram to prove it to the surgeons that there is a TRAS. So they the kidney was on the right side. The approach initially they took it from the left femoral. They didn't want to puncture the right. But then the interventional radiologist did the placement from the right only, sir.
Hello, but actually the right way is to do it from the left only. That is easier to enter the cells.
So
Yes,
in the
sir.
early phases, sorry.
Yes, sir.
So in the early phases, it's a TARDIS. You won't see TARDIS, the form that you're talking about, typical ones, because there's a lot of edema and everything. So any suspicion, I know they are saying their TRAS is not an indication. It's better to do an angiogram. At least angiogram, then you can prove or disprove, saying that, okay, stenosis is ruled out. Then you can, you already done biopsy, which has proven there's no rejection and everything. So
yes, sir.
I think angiogram should be an early phase.
Yes, sir. We didn't have that in our mind because initially they told that the renal artery perfusion is good. So we really didn't suspect this to begin with. But when he started building up so much volume, he was behaving like the single kidney, single clip or double kidney, double clip model. So that's when this suspicion came into pictures.
Thank you.
Thank you, sir.
Bala, sir, I have a question for you and to others. So of late with repeated regular ultrasonograms, Dr. Changuton, radiologist at my unit is also there. We started picking up this patterns, power set TARDIS pattern suggesting a potential TRAS very commonly, rather in the say second or third weeks where there are no other indications like there is no hypertension or is it reasonably controlled, there is no worsening renal function. But we know for sure, like I know for sure when he is telling there is a power set TARDIS pattern, I'm sure like there is something. And we sometimes end up doing an MRA and documenting a significant TRAS. And maybe once or twice we have intervened also. But in the presence of a documented clear-cut TRAS as per Doppler, MRA, or even let's say CT angio, there are no other strong indication in the form of a worsening renal functions or a difficult to hypertension, what would you do, sir? Should we still intervene, or we should really wait for the renal functions to decline? Because every time creatinine shorts up a little bit, you always think like that is the reason. So how do you proceed in this situation?
Well, I think you should treat it like a native kidney renal artery stenosis only. Like kidneys can get away with up to 50% stenosis or even more, unlike the heart, for a very long time. So you should not jump and do. But this Parvus Stardust, I always believe it not only shows the diagnosis of renal artery stenosis, but tells you about the reversibility of the hemodynamics. If you correct it, there will be definite hemodynamic improvement. But I think you may not do it in a hurry, but you should. One day he would require. Because this is going to be a single
Sir,
kidney and yes.
I have a question for Venki sir. Sir, what were the peak systolic velocities at the site of stenosis, sir, when they had Parvus and Tardus?
Yeah, generally it is above the recommended. No, we say it should have to be more than 200 or 300 centimeters per second. We have all those things in those range, but only thing is there is no other strong indication for us in the form of hypertension or renal dysfunction. So in the transplant, as Dr. Balas was telling, we want to manage it as a regular native kidney situation. But like in a transplant situation, is not all that. It's easily said and done.
Sir, when we in very early time when we do this Dopplers and RIs and PSVs, the thing is initially the kidney is swollen, but there is some edema at the endothelium also. We routinely do sonography and RIs in all our patients, and in the morning our residents do. So what happens is in early phase there is edema at the endothelium also. Early RIs tend to be low. They are generally between 0.55 to less than actually 0.6. After a day or two, generally they start to increase, and then in an average they around settle at around 0.6, 0.65 in an average. And then the classical thing they say for native RI below 0.55 or 0.5, which suggests renal artery stenosis. In early time, it might be because of handling of endothelium, edema of endothelium. So in very early phase, generally RI is not very reliable. We have to actually localize in Doppler. In the case which Pooja ma'am also said, that there was some difficulty in picking up the renal artery stenosis, because at that time we have to actually visualize the renal artery in Doppler. And many radiologists, because they don't routinely do localization of transplant renal artery, they generally fail to localize that. So in our case also that happened. Our routine radiologist was not available on first sonography. Ma'am did sonography. She found out that perfusion is very good. And RI was also not very low at that time. On next day, we found out that the PSV was very high compared to the feeding vessel. So that's what.
One question.
So
yes, sir. Please, sir. Dr. Ram, sir, go ahead.
Okay. So those typical situations, you have to have a repeated Doppler in a short span of 48 hours for 3 times. Not only RI, like Akash was telling, peak systolic velocities. So compare everything. So you'll find one thing which is not behaving as normal. So that's an indication saying that, okay, you're not going in the straight path. And that's an indication to say early intervention might be best for this one.
Angio at least.
So,
if renal function is absolutely okay, we can do CT angio.
Well, and about early intervention again to Dr. Bala sir and others, including Dr. Ram. So if at all we are pressing, again being pressed against the wall with an early onset TRAS, and you may have to intervene, and for some reasons you are unable to ask your surgical colleague to intervene. How about using a covered stent, particularly in a end-to-end anastomotic situation?
Yeah.
See,
it'll be
go on,
the luxury, and if available, I think nothing like it.
See, when none is available, whatever is available is best.
Yeah. But maybe
Okay.
in very early period, like, first week of transplant or so, I think it'll be safer to have a covered stent. If it
See,
is
the other thing you have to look at is the delivery system. So the more sophisticated, covered and everything, the sizes differ. So you have to take into account what is the smallest size sheath that I could use, and still deliver the stent, which is the right one. This all matters. So self-expanding, covered, these have like a difficulty in the distal end of the tip of the catheters. So recently I placed a balloon mounted stent in hepatic arterial anastomosis. Okay. While going from the celiac to that, the balloon got dislodged from the stent. So the balloon got separated from this one. This is because of the angulation and everything. It got hit to the wall and got separated. So the same thing can happen anywhere when there is a tortuosity and everything. So it all depends what size, what is the angulation and everything. So there's no difference because there's no other arteries you are protecting there. There's no collaterals.
Yes.
So it should not be different between a covered versus non-covered.
No, you need not have to worry about the potential rupture. No, that was the essence of my question.
Maybe in the very early stage only. I mean, within a week or within 2 weeks. Otherwise, yeah, but it is safer. But I could never have that choice. And I mean, before we close, I'll show me because I'm fond of contrast ultrasound. I'll show you the contrast ultrasound done in this patient before and after. Yes. Oh. The reset. There's all these video files. Ah, yes. So this is the contrast ultrasound.
On the number invite coming.
You see that there is very little contrast, entering the cortex. And I'll show the one done later also. It takes so long to perfuse, and yet the cortex area is not getting filled with blood. So I usually take for 1 minute. It doesn't perfuse the whole kidney at all at the end of 1 minute. So this was the day before or the day, just prior to our stenting. Then this is the one done 2 days later after the stenting. You see how nicely it has perfused the whole kidney, but you just see that it didn't happen in one pump, one pulse. It took 2-3 pulses to reach the periphery. So I had the pleasure of having these 2 pictures done in my case. So I think, thinking back, hearing all your stories, I think I would have been a very rare case where I see a case with CKD, I initiate on dialysis, I work up for transplant, post-transplant, diagnose renal artery stenosis and do a stenting myself. This is not to pat myself, but I think God gave me the opportunity to be in the right place in all this and get this done in a few of my patients. Thank you. Yes. Any other comments to? I know because mostly, this is given to interventional radiologists or cardiologists, or if it is surgical, the surgeons. Not everybody will have the opportunity to do it yourself, but I think we should get in the way, and that way we'll be able to at least make decisions quicker and faster, and we can always take help from others, but I think we should get used to these things also. Any comments from Adrian?
No, I've had a similar case that I wrote, but we stented. It was pretty straightforward. And I was just wondering, when I saw my patient, I managed to find a bruit. Did you guys manage to hear any bruit with your
Yes,
patient?
yes, yes.
Yes, yeah,
It's actually
yeah. So
very clearly audible because it's
right,
just below 2-3 centimeters below skin. It's commonly audible.
very unknown. And then our patient blood pressures went up, and he went on to 7 blood pressure medicines. And so when I was in the transplant center, that's when something was off, and we did a CAT scan straight away, and we put a stent. For me, it was interesting to hear from Dr. Ram that they do CO2 because I don't know whether CO2 can. It's very accurate. It will not help us size, right? Whereas the CAT scan will tell you accurately the readings as opposed to a CO2 angiogram.
So, I mean, yes and no. CO2 definitely doesn't tell you the lumen, this thing, but IVUS is perfect because IVUS doesn't need contrast. So we use IVUS, and it will also give you the landing zones also. So
Correct.
And Adrian, actually with good technique with 5 to 10 ml of iodine contrast, you can take a good study of the
Right, right,
Yeah.
right,
And
right.
it's
I
not
agree.
very unusual. I mean, as far as you reach the internal iliac or the external iliac, that is enough. And 5-10 ml contrast, but I think that wouldn't make any harm. So we did not go for carbon dioxide and get an inadequate picture and things like that. At this case, I didn't have a biopsy. I didn't look for tacro level, nothing, no confusion. And the whole picture and the history of Army was there. So everything was in front of me. So directly I went even for CT angio and rushed her to the cath lab.
The other question I had, corresponding to what Dr. Ram said as well. Since you didn't have the correct stent size, could you not have ballooned and just waited for the stent to arrive? Would it not have helped the next day?
Yeah, that's a point. But I'm wary of doing only plasty rather than stenting in the renal arteries because fear of dissection and thrombus and things like that. So if you come out after putting a stent, you are sure that the walls are being held away, and there is. So the time between the pre-dilatation and the stenting itself, my heart used to, because
Right,
I've seen
right.
in elderly native renal artery stenosis, your vessel getting dissected and the whole kidney being blocked. So actually, I
I
presented
see.
somewhere the story of a kidney which refused to die. So this was I think I'll put it sometime later. So where I was trying to do stenting, and it was a tossed kidney. So from the femoral artery, I could enter the renal artery with the with the diagnostic catheter and do the study. And the guiding catheter was there, wire was there, but the stent was long and stiff, so it wasn't slipping in. It was pulling out the guiding rod. It generally happens. I think Ram and others will know. So repeatedly I tried. Then I had to go through the brachial artery, come from the above, and the difficulty was even actually was more thing because of calcification. It was a very old man in the origin. So all the 2-3 pre-dilatation balloons actually ruptured. But in that process, he dissected, and that kidney, in front of my eyes, a dye was not going into the kidney at all. Whereas few minutes ago, it was perfusing well with stenosis. It was a bilateral renal artery stenosis, and one kidney was very small and useless. So no point doing anything, and that kidney was not giving any useful function. So only the one was giving some useful function, which was stenotic 90 to 95%. So I was very sure this is going to help him. But this ended up in dissection, and the whole kidney didn't perfuse at all. So I was so upset, because this is going to be very obvious, because it is not going to take time. It was single kidney and you have blocked it, so from very next day he's going to have problems. But but I had put the stent and put 2 more stents to cover the intimal dissection. But still the perfusion was not there, and patient was not doing well. He was sinking in the theater, so I quickly shifted him to the ICU, and praying that he will at least survive. The kidney is lost for sure, I thought. And the next day I was to travel to some place for a conference. So this was happening as usual. I did in the night. It was 11 o'clock, 12 o'clock in the night. So I waited for some time in the ICU. Patient was hemodynamically stable. Sheath was not removed, but because the cath lab people didn't want things to turn bad in the cath lab, so they quickly shifted him into the ICU. But to everybody's surprise, he gave us enough time for himself to settle down, and the sheath sheath could not be kept. I had put in a balloon also. It was not only dissection, there was bleeding outside at the calcified spot. So I shifted him with a balloon, distended balloon in the bleeding spot. So later, early morning, the balloon was deflated, nothing happened, patient was stable. Then before going to the airport, I went very meekly to see the patient, how he is. To my surprise, he got up, sat, and he was sort of என்ன சொல்றது, doctor, you saved me. I only knew how I nearly pushed him to the other end of the wall. Then this kidney started functioning, and he went home with good urine output and creatinine around 2 or 2.5. So this, I put it as a kidney which refused to die in spite of all our intentionally good maybe, but bad efforts.
Balasubramaniam, Dr. Vinand wants to share one of his case. Can I do that? Can I share my screen now?
Case? Yes, please.
Yeah. So can you see?
I think it's getting uploaded. Yeah, can you just play the video? I'll just give you. Yeah, I'll give you a background. If you play this video, so this is native selective renal angiogram of a young lady who comes to us with history of fever about 6 months back, and now she has accelerated hypertension, uncontrolled hypertension, and she comes to us with this kind. She comes with a Doppler which has a peak systolic velocity of about 250, and we do an angiogram here, and this lady is on dialysis right now. So just wanted to know the opinion of the house. What do you think is going on here? Then I will just allude to how we did this.
How's the other side?
So the other side is almost occluded. This was the only functioning vessel. The other side is totally occluded. So what should we do further now in this case?
Well, although the vessels look pruned, giving an impression of bad thing, but I see the cortex getting opacified, telling that there is perfusion till the terminal cortex.
Vinant.
Good sign.
Vinant.
Yes.
Do you have any other image? Because this is not a normal looking, because if you look at the main renal artery is wide open and is a good size. Suddenly your catheter is in a vessel which is a very small caliber. So are you missing any other vessel before that one?
So I'll give you a background on what happened. This exactly happened just a couple of minutes back. So that's why I was
okay.
busy.
No, what I mean to say, so pull back. Your catheter is your catheter is too far inside.
Maybe.
Yes, that's right. That's right.
So you're yeah.
So what we did was what we did
Yeah,
was that we had already analyzed, and we had the opposite, the contralateral renal size was, the kidney size was quite small. So we didn't want to do an angiogram on that side. And that's the reason why you can see the catheter way up there, because we were not attempting on the other side. So what's happened here is that once we pushed in the contrast, you'll see that, look at the amount of resistance that you can see coming back again into the aorta, and a very less blush going into the renal artery. So into the arborized vessels. So we took this case up just a couple of minutes back, and we decided not to do anything with this patient. This patient has been on dialysis since the past 1.5 months now. And we noticed that because the blush, there's such a high resistance that's coming out. And the reason that I put this case up is because we thought this was a patient that was amenable to renal angioplasty or maybe a stenting because of the peak systolic velocity. But once we did this angiogram, we realized that there was such a lot of intraparenchymal pressure that was transmitted back that we've aborted this case right now. I just wanted to just put up this case on how we stopped ourselves from putting in a stent here. And I wanted to know if we are correct in what we did just now.
As Ram said, I think you should pull out the catheter a bit and take another shot.
Okay.
So the other, yeah, go on, sir, go on.
Yeah, carry on.
Even intraparenchymal vessels are not normal looking, the way they are appearing. They're very widely sparse, thin, very thin. So a lot of parenchymal disease, I can say, from the angiographical view. Definitely, a proximal angiogram would have been better to understand if any other blood supply has been there. So.
Okay,
Yeah.
I think that's what we'll do. The patient is still on the table, so I think that's what we'll do now.
Vinod, actually, time and again you'll see, typical renal artery stenosis, but the intrarenal vessels would be pruned like this, but you will not have a cortical blush like this. Am I not right, Ram? If it
yeah,
was
I agree with you. Agree.
Disease.
Yeah. So, yeah. Vinod, if you proximally, if you see the same pattern, do an iotogram, because you might be missing something, blood vessel or something, so dual renal arteries or something. So do proximal. If you don't get anything, same picture, do an iotogram.
Can I make a comment on this?
Yes.
I'm Suresh from Dallas. At the end of the day, what I feel is, I don't think this patient will benefit from stenting. It will make only things worse because the patient has so much intraparenchymal pruned up vessels. If you put a stent, it's only going to make it worse because you're going to put more flow into the kidneys and it's going to prune, the vessels are going to prune down. I personally feel that any intervention on this patient will be of any benefit because this has been a long time problem. She won't benefit from it.
But Suresh, the only point.
Yeah, totally agree. Yeah.
Yeah, but the only point, why I'm not too sure about the irreversible problem here, because the cortex getting blushed.
Yeah, I get that. Yeah,
so,
but that's what
if only the catheter is withdrawn a bit and another study is taken, maybe we'll have a different picture. Because in coronary, post-stenotic small vessels get bigger once you get across the stenosis. I mean, once they balloon the the narrowed part. So that I again seen in cardiology. So something like that can happen here also. I think before giving up, Vinath, I think flush study from the aorta or catheter withdrawn and repeat study, before giving up.
Okay, sir, I'll do that. I'll do that. Thank you very much. But I still felt that the blush.
Yeah, I'm happy about the blush I see in the upper pole. Then before you leave, and Suresh and Adrian and Sampath and all had to say a lot of things appreciating Vinod. I think quickly, Suresh.
Yes, Vinod, hats up to you. Congratulations. This is a mammoth colossal work you guys have done. It's not just Vinod alone, Bala sir and Prashant. This is amazingly, it's like a scripture. It's like for interventional nephrology, this is like a kind of Bible or Gita, whatever you want to say. It has got all the chapters are amazingly selected and a lot of work put into it. And I'm sure this will be a basic go-through book for anyone who wants to continue and aspire to become an interventional nephrologist. and it's well done, and big congratulations to and also the rest of the contributors have given all the contributors are big time people and put in all their effort. And also thank you, Vinan, for pushing me, nudging me very politely to finish my work, because I was finding it difficult to finish. I was going through a hard time, and my time was a problem for me during that time. I was going through bad times and with whatever was going on, and you nicely nudged me to finish it. And I was letting Bala sir know that after I finished, and I just thought, what is the limit to this? Because sky is the limit. A lot of things can be said, but is it going to be practical? And I finally entered it and sent it back to the publisher. And then I was thinking, man, I could have done more. There is so much. But then, one of my kiddo, she's a doc too. I asked, hey, can you read this and see? She said, enough is enough. This is, medicine is a very dynamic science. What you know today, tomorrow is different. What you do today, tomorrow is again different. So what you know today is what it is, and you cannot keep going on digging more and more. So I was initially unhappy, but then I came to terms with it. It is good, and I really appreciate what you've done. And as I said, Bala, I'm going to buy 2 copies, one for me and one for a friend, and that'll be good so that I can read the rest of the chapters. And thank you so much, and also allowing us to write the book. Few people from this side of the continent, like these are all veteran people, and so I think we appreciate you for including us in your adventure. Thank you so much.
Thank you. Thank you.
Yeah, thank you so much, sir. And I would like to thank Dr. Bala. I think he's the one who's propelled the entire project. He's the one who said that he wanted to have such a book when we started this about years back. And that was, those words just kept us going on together. And I would really congratulate all the contributors. They've done a fabulous job. And for all those who think they still got more to do, Dr. Bala and myself will be coming out with the second edition very soon. Let the first edition run its own length, and then after that, yes, and Adrian, you will be a part of it too. We're going to trouble you again.
Gosh. Anyway, I just wanted to say thank you. Every time I hear from Vinant, I feel like I'm contributing back. I'm giving back to the country of my birth, to honoring my mentors. So it's always a pleasure to hear from Vinant. Congratulations to all 3 of you, as a matter of fact. This is hard work. I love the color because purple is the color of LSU. That is my institution here. But I also love the videos that are in it that no other, I think, book that I know of has it. So you've gone that extra mile. And so maybe next time you can have cases and you can have videos on this as well. You can show what people did. Maybe that's the next level that you can go to. But, like Suresh said, you gave me my topic and you were the first one to give me what you wrote. And I was like, wow, this guy is writing so fast. So congratulations, well done. And, thank you for letting us all be a part of this. And we're looking forward to part 2. Yes, of course.
Right.
Dr. Bala, well done to you too as well.
Thank you.
Yes, Bala is innovator and the veteran of all this. And
I have a feeling. I have a feeling this will be when the next avatar comes out. He'll say book 3 is coming out. Book part 2 is coming out.
The thing is, I've never seen a book. I don't think, Adrian, I think you should agree. Even though Dr. Bethard started all this many years ago, there are here and there literature and books, but I've never seen such a entire thing in one place. It's one place to go, and you don't need to go anywhere else and look for it.
Yeah, I agree. In fact, I was thinking if I can get
this is amazing. I'm seeing it.
I was just going to add that if I get this book, then it'll be a book that my fellows will go through. They would love the videos because it is, we can sit and teach them through these videos. So I can't wait to get a copy of this book for my fellows.
Yeah, exactly, I fully agree.
Is there a digital link, Dr. Bala, that we can get?
No, I don't think so. Vinant?
No digital link. Okay. I think he ran away.
Yeah, we let him go back to the theater. Okay.
Yeah.
I think, thank you, everybody. I think we had a good number joining also. As I was telling you in the beginning, for simpler topics, there are more audience actually. Sometimes you think you have a fantastic topic, very rare things you have done and all that, but not much takers because that may not be relevant to them. Anyway,
That's
we
true.
had a good discussion today. I thank Dr. Muthu for giving your wisdom. And actually, the point that Whaler and I think we'll stop here, and
Okay.
we'll be discussing on native kidney renal artery stenosis sometime later. I think we may have more to add. Thank you, everybody. Thank you.
Thank
All
you.
right.
Thank you.
Thank
Good
you.
night.
All right, bye. Good night.
Good night.
Adrian, have a nice day, man.
Mm.
You too, Suresh. You too. Good to see you.
Thank you. Nice seeing you always.
Bye-bye.